All right, so it's 8 o'clock, so let's get going. So good morning, everybody. Thank you for joining us on this Saturday morning. If you're new to our lecture series here, welcome. Prior to March 2020, we did these in person in our Waltham location of the McKaylee Center, but we hope to get back to that. But for now, virtual is working out really great for us. So if you're a returning viewer, welcome back. We're happy to have you here. Learning with us this morning. So this lecture is going to be recorded and it will be posted to the YouTube channel in the middle of the next week. So I think we're ready to go. And so we're going to welcome our first speaker. It's Dr. Andrea Stracciolini. She's our Director of Medical Sports Medicine at Boston Children's Hospital. So thanks, Dr. Strac.
Thank you for having me, Emily, and for being here this morning. I'm really excited to present today on a topic that I'm passionate about. I've been taking care of athletes now for over, I don't want to date myself, but for over 20 years. And I've learned a lot, and I'm hoping to share some of that with this group today. So I'm fortunate to be here and fortunate to be part of the McKaylee Center for Sports Injury Prevention. So I have no disclosures as they pertain to the topic of this talk today. So I'm going to start off with a brief tribute to our founder, and that is Dr. Lyle McKaylee. And he really, his legacy is to prevent sports injuries in young children. And he really is the one who conceptualized the concept of the overuse injury. And you'll see I highlighted this reference, which really dates back to 1983, which he talks about overuse injuries in children's sports, the growth factor. And, you know, now over 30 years later, we're really not much further in understanding these injuries. And even more importantly, we're not much further in preventing these injuries. So he really talks about the growth process as a risk factor for sports injury in young athletes. And the name or the term is overuse injuries. And I think a better term is repetitive stress injury. Because we really don't know if these kids are overused. We see these injuries in kids that may not be overused. And to really define an overuse injury, you have to know how much use they've had. And sometimes we don't know that. But nonetheless, it is a repetitive stress injury versus an acute traumatic injury. And we do think that children may be more susceptible because of their unique vulnerability of their growth cartilage, that vulnerable part of their skeleton that is developing and actively growing and changing. And then along with that, the growing soft tissues. And we know that during this process, and Genna and Eric will talk a lot about this, there's biomechanical imbalances that ensue. So I try to avoid strength, like weakness, or inflexibility terms, but I talk more about imbalances that ensue during that growth process that really affords these children a risk for injury. And we're right now in a conundrum of sports, right? So is it too much too early, organized sports and specialization, which is a whole topic in and of itself. And if you're interested in sports specialization, we are having a whole McKaylee lecture symposium in the fall that's going to be awesome, and we're having Dave Bell and Dr. Jayanthi as guest speakers. So if you're interested in that topic, I touch on it today, but I don't go into it in detail. But it does segue into the sports overuse injury topic. And then, is it too little diversification, too little free play, and too little attention to health and well-being maintenance in our young athletes? So we know we're in a paradigm change of youth sports. We know that kids are playing at a greater intensity at younger ages. They're playing at higher competitive levels at younger ages. Their focus tends to be or can be more of a single sport focus, and their goal is to achieve greatness, whether that be, you know, playing on an elite status, playing, you know, for the professional stage someday, or in the Olympics, or is it scholarship and money focused? It's hard to say, but nonetheless, we know that there is a focus for single sport participation. We know there's pressure from people around these children, including parents, coaches, and scouts. The drive can be for just performance, can be for, again, that elite performance on a professional stage, or it can be money-based. And for the pediatrician in me, I think importantly, we have a shift away from free play and family time, which is very important in developing our young athletes with regard to mental health, and well-being, there's less attention to the promotion of sustained physical activity, which should be, in terms of taking care of our young athletes, that is our goal, is to encourage sustained physical, successful activity throughout the life course. So let's talk about the epidemiology as a continued introduction. So we know that 60 million children and adolescents participate in some form of organized athletics. We know that about 46% of youth sports injuries are overuse injuries, and I'll show you some data that supports that. We know that more than 3.5 million children less than 14 years receive medical treatment for sports injuries each year. And we know that children 5 to 14 years account for nearly 40% of all sports-related injuries treated in the hospital. So this is a study that we did, now it's dated roughly 7 years ago, but it was a sample of young children's injuries that present to our clinic at the Children's Hospital Division of Sports Medicine. So we took a random sample of all injuries presenting to our clinic, and we looked at children in the younger age group, so roughly 12 to 17 years. And what we found was, by and large, over half of the injuries, over 50%, were in fact overuse injuries. And then when we looked at the breakdown in terms of sex, the females tended to have, just about 2/3 tended to have the more overuse injuries versus the male counterpart, who tended to be more traumatic. And people tend to view these injuries as benign. And I think importantly, what we found here, and this is that 40% of these injuries required surgery. So even though they're repetitive stress injuries and they often get better with correct treatment, they're not always benign, and I'll show you some examples of that. And importantly, this is biased because we have a lot of surgeons in our practice. They are a big referral base, so this is likely an inflated number. But I think the point remains that these injuries are not always benign. So how do we define overuse injury, or that repetitive stress injury? So for those of you who really are interested in this topic, I will point you to this reference by Dr. DiFiore. And this was a position statement for AMSSM, and it did get a lot of press when it came out. It's excellent. It's a great review, and it really helps define this injury and looks toward how we can prevent it. And so overuse injuries occur due to repetitive submaximal loading of the musculoskeletal system, that vulnerable musculoskeletal system in our young athletes, when rest is not adequate to allow for structural adaptation to take place. So these kids don't have time for this repetitive stress to this vulnerable skeleton and soft tissue, and they're not afforded the rest and recovery time for healing and adaptation to take place. The injury can involve different levels. So we think about things in levels. So is it at the bony level? Is it at the soft tissue level, that muscle tendon unit? Is it at the bursal level, so an inflammatory process? Is it a neurovascular structure, or is it at the growth plate, that vulnerable area where the bone lengthens and grows? We know that overuse injuries are unique to young athletes and include we know that overuse injuries that are unique to young athletes include apophyseal injuries, and that apophysis is the attachment of a soft tissue structure to a bone. So I'll talk about that in more detail as we move forward in this talk. So this is a unique injury to our young athletes. It is very treatable, but should be recognized early. And then the injury to the physis, which is that growth plate of the young athlete, that is very important for lengthening of the bone. And as a pediatric sports medicine doctor, I really have to be attuned to injury to the growth plate and the apophysis, because it can affect further growth down the line. So what are risk factors? So we divide risk factors into those that we can control and those that we can't control. And so the intrinsic risk factors are those that we can't control, but that we'd like to recognize. So Dr. Michaeli really points out that important growth, that rapid period of growth that leads our young children vulnerable to injury. We know that they have susceptibility of their growth cartilage to repetitive stress. We have to be aware of the adolescent growth spurt, and I'll talk about peak height velocity in the next slide. We have to really pay attention to kids who have had a history of a previous injury as a red flag for a future injury. We have to look at level of conditioning. Eric will talk about that, I'm sure. We have to look at anatomic factors that place these kids at risk. So do their Do they have genuvarum or genuvalgum? Do they pronate at the ankles? Are they tight? Are they loose, etc.? Very important in looking at our injury patterns. We have to look in our young females at their menstrual history. Is there a history of menstrual dysfunction? I'm not going to get into that today. It's a whole separate talk, but very, very important. There's a lot of myths that surround the menstrual cycle in the young female athlete that need to be dispelled. And then we have to pay attention to mental health. It's a huge factor right now, and it continues to be a large factor in our young children. And we have a huge staff at the McKaylee Center that really pays attention to the psychological factors of the young athlete. And then these are the factors that we can control, the extrinsic risk factors. So training workload and how we navigate that. Training and competition schedule, so we have control over that. Equipment and footwear, so the cleats, the ballet slipper in our young dancers, for example. The environment, right? So is it hot for our young football players? And then sport technique, are they trained and ready to participate in their sport? And Eric will talk about that, I'm sure. And then, the people around them we can control. So who are their influences? Do these children want to play their sport, or does their parent or coach want them to play their sport? So important things that we can control and work on. So I'm going to talk about peak height velocity and injury risk. So this is an important slide for people to understand, because I think it is a time where we can really help these children navigate the pubertal growth spurt and help prevent injury. And I don't think we're doing a good job at that with this at this time. So peak height velocity is a time where the biomechanical or the biochemical properties of bone in fact change. So it's a time of rapid growth, and the bones increase in size more rapidly than they fill in with mineral or density. And so in fact, during times of rapid growth, and I know you all have seen the young male who's gone through these rapid growth spurts, especially in the summer when they're eating a lot, their bone mineral density in fact decreases before it rebounds after peak height velocity. So they are in a period of skeletal fragility or weakness during their peripubertal growth spurt. So we see this in females and males as they go through rapid growth. In the females, it's usually that year right before the onset of their menses, and then a year or two after their menses, but really that year right before their menses, they go through rapid growth. And it really affords them a temporary increase in fracture risk. And this is when we have to really pay attention to volume and training load in our young athletes. We know that there's a higher rate of injury in our pre-pubertal female gymnasts versus gymnasts at higher and lower stages, regardless of competitive level. And so that was a study by Kane. So we know this, so it's rate of injury. And it is a time where that skeleton, that immature skeleton, especially in the gymnast, that pounding, and it's at a time where they're seeing increased volume and increased demand as they're continuing to go up their training ladder. We know that gymnasts 10 to 14 years are more likely than older gymnasts to have chronic wrist pain, even after adjusting for sex and training factors and intensity. So we know that these kids are more prone to injury, and the research does seem to support that during these rapid growth periods. So what are the most common injuries of growth? So here's an anatomy picture of the skeleton of a young athlete and that vulnerable physis or growth plate. And that is depicted here by this line right through the bone here at the distal radius. And this is the wrist joint. These are the carpal bones or the wrist bones. This is the ulna. This is the radius. And here is that vulnerable growth plate. And what I show people on the x-rays when I see these injuries is that when a young athlete comes in with wrist pain, even though the x-ray looks normal, I worry about this area of skeletal weakness, this physis, and is there a stress injury there? And oftentimes the radiographs are normal, but with a careful physical examination, I can detect a stress injury to the growth plate and help guide these athletes. And then the area called the apophysis. So this is the area where the soft tissue, and in this case, this is the knee joint. This is the vulnerable growth plate of the distal femur and the vulnerable growth plate of the proximal tibia. And this is the apophysis. So this is the soft tissue attachment. In this case, the patellar tendon, which you don't see on a radiograph, attaches to this vulnerable growth plate. And it can be widened, it can be pulled off, you can have a little bony ossicle there, so you can see all different injuries there. And I do musculoskeletal ultrasound, and oftentimes I can put the ultrasound on there and see bursal inflammation. I can see the patellar tendon inflamed or even slightly injured, and I can see bony fragments here that you often can't appreciate as well on the x-ray sometimes. So the ultrasound gives us a lot of information in this regard, but nonetheless, more often than not, you need a simple x-ray and even just a good clinical examination with pressure on that apophysis, and ask the young athlete, does it hurt when I press there? Have them extend their knee against resistance. Does it hurt when you do that? If the answer is yes, and they're young, more often than not, the diagnosis is an injury to that apophysis. And then the growth plate, as you know, is where the long bone grows. We have to be really careful about paying attention to that area. Oftentimes it's an increased load from compression, and then the apophysis, as I talked about, is that myotendinous attachment from repeated tension and traction on that area. So this is a unique injury to the young athlete, which I think is important to be aware of. And they can be tricky to detect. So this is an osteochondrosis, or a disruption. It's a big, long medical term, a big disruption of the endochondral ossification. So again, this is an area, this is the elbow joint, this is the radius, the radius of the elbow, the ulna, this is that vulnerable growth plate of the humerus, and this is injury to the bone cartilage interface. And we don't see cartilage on this x-ray, but we can see a lucency here where the bone has been insulted, if you will. And it really is from repetitive stress. So we see these injuries uniquely in our young athletes who are loading their elbow. So think about the young gymnast who's made the upper extremity a weight-bearing extremity, which it really is not. If you think about it, the only people weight-bearing on their elbows are the gymnasts who are impacting their upper extremity. And we see these unique injuries, an overload injury to the bone of the elbow. We know that there's repetitive stress across the physeal, and that presents clinically as pain, inflammation, and then fracture. And we can see the fracture at any level. We can see a stress injury, the diaphysis or the long part of the bone. We can see it at the metaphysis, just above the physeal here. We can see it at the growth plate. We can see injuries at the growth plate or even in the epiphysis. So all areas of the growing skeleton are vulnerable. They often present as inflammation and unlocalized pain. It's often, as I said, during periods of rapid growth. So beware the physis, and it's more prone to injury because of the weakness. Overuse injuries of the physis occur in active adolescents between the ages of 8 to 15 years. So that's really when we think about these injuries. And we know that male athletes 1 to 2 years later than females present with these injuries due to later growth plate fusion. So remember, the growth is a little bit delayed compared to the female. So this period of skeletal vulnerability is really extended in the males versus our females. So we can see it over a longer period of time. So let's talk about some unique injuries that we see. So gymnast wrist. So this is, we see a lot of gymnasts in our clinic. And there is this entity called gymnast wrist. And what this is an injury to the radial physis, so the growth plate of the wrist bone, the distal radius. We know that it fuses by 15 to 18 years. So that young gymnast in that time where she's loading, so here's a cartoon where she's loading her wrist. She may not have the core strength or the shoulder or the upper extremity strength and flexibility to adequately support her wrist. And then she injures that growth plate. So they often present with vague wrist pain. It's usually on the dorsum of the wrist, and they often have focal tenderness just over that growth plate. So we can make the diagnosis fairly quickly with a good history and a very detailed physical examination with palpation carefully over the distal radius. And we know that it's vulnerable during that adolescent growth spurt, as I talked about. we often will get radiographs and we see irregularity of that growth plate. So the radiographs are really important. And oftentimes I'll get both because remember the gymnasts are loading both wrists. Even if the other one doesn't hurt, I often, not always, but often will use it for comparison to see if there's subtle changes in the more symptomatic wrist. And you can appreciate widening of this growth plate. It's fuzzy, it's not as clear. And this tells me that, and then when they have a physical examination that supports this, this tells me that they have an injury to the growth plate. So we know that competitive gymnasts frequently demonstrate delayed skeletal maturity. They may present with radial or physeal injuries 1 to 2 years later than athletes in other sports because of that delayed skeletal maturity. So we see that in dancers and gymnasts. We see radiographic changes of the physis. So 25% of non-elite gymnasts and 83% of elite gymnasts at European championships have been shown to have often have changes of their distal radial physis. So how do we treat this injury? So it really, we use this term in pediatric sports medicine, a relative rest period. So we rarely put our athletes on the couch and take them out of everything. And if you do that for a gymnast, it can really be detrimental, both for their mental health and their physical health. So what I'll do is I'll rest their wrist and have them participate in the gym, condition in the gym, work with the trainers, but avoid loading of the wrist. And you'd be amazed at what the gymnasts can do without landing on their wrist or loading their wrist. So I'll have them rest their wrist totally, but allow them to continue to condition and stay fit. I'll often keep them in the gym for conditioning, really to preserve their sense of who they are, their identity, and to, more importantly, to keep them conditioned. So I'll have them non-loading or weight bearing of the upper extremity until the pain is totally resolved, usually a minimum of 6 weeks, but that can vary. I get them into therapy to really look at the shoulder mechanics. Is their shoulder tight? Is their upper back and core, their periscapulars weak? And I think that's really important, especially in our youth of today who tend to, when they're not playing sports, tend to be less active with the pull of technology. Their posture tends to be not great. So I do think a therapist who's skilled in treating these young athletes is important to work on strength and stabilization. You can consider protection of the wrist when they're cleared, including something called tiger paws or wrist guards, but you really need to be aware that there is no research to support that these truly do prevent this injury or really do anything. But some of the gymnasts really want to wear them, and I reassure them that they can, but it should not take the place of their strength and conditioning and monitoring for pain. So what are the risk factors? So in the gymnast in particular, it can be very soft mats, affording an increased wrist extension. It can be doing twisting elements on the upper extremity with a fixed forearm. It can be improper technique. So we make sure that they're looking at the way they're loading their wrist. It can be a volume issue, just too much, simply too much. And then if we make sure that we take a careful history to ask about previous injury. And I really use the opportunity in the clinic, if they have a history of an injury, to tell them that this is a red flag for future injury, and the time for injury prevention is now to prevent future injury. Thus, why we've created and now have 2 Micheli Centers for Injury Prevention. Return to sport, there's no hard and fast rule, but this is a good one that I like. So 75 reduction rule. So the gymnast should return at 25%. So it's all about gradual return to sport. So they should return at 25% of their previous skill level. And then each week they can reassess and increase their amount of load. So it is a gradual return. And I think people, that needs to be emphasized when you're returning these young athletes from their overuse injury, that their return should be gradual, and their schedule doesn't always allow for that. And that can be really difficult to navigate. But it really is an important concept. And most people get it, but it's hard. You have to, again, make sure that they have proper technique when they go back, that their equipment is in good shape and proper. And again, wrist protection if they want to use it. And then, think about decreasing volume and load during times of rapid growth. I know that's not quite realistic, but I think we're going to get there in the future as we start to really dissect these injuries. Let's talk about Little League shoulder. So this is a unique injury to our young baseball players. It's also known as osteochondritis. So there's a lot of terms in the literature, so people get confused. But nonetheless, it's an injury to the growth plate of the proximal humerus, as this arrow depicts here. So you'll hear the terms osteochondritis, epiphysitis, epiphyseal lysis of the proximal humeral physis, and simply stated, it is a stress injury to the proximal humerus. We often, it's called Little League shoulder, but it really is a misnomer, as it usually occurs in an older than 12 athletes, so they're usually out of Little League. The peak incidence is age 13 years. And this is really a distraction or torsion injury. So see this young athlete with their hyperextension of that, they're all arm at this age. And I think that's simply stated, there's too much stress on the upper extremity, not enough use of the core that is usually relatively weak and tight. And Eric and Genna will talk a lot about that. Similar treatment to gymnast wrists, we relatively rest them. Genna will talk about the therapy for shoulder and looking at shoulder mechanics and how to rehab these athletes. Importantly, stretching of the capsule, both the anterior and posterior, that sleeper stretch, that door jam stretch, and looking at periscapular stabilization, all really important, and important to teach these young athletes at an early age. So the apophyseal injury, so many of you may have seen, I'm sure you've all seen this, honestly. So this is Hodgkin-Slaughter disease. It's an injury to the physis of the tibial tuberosity. And this is a very irregular one. That's why I picked this x-ray. And you can even get a shadow of the patellar tendon attaching here. And they may look awful and not even be that symptomatic. These are the kids that come in with that bony bump just below the level of the kneecap, and they're like, it hurts right there. It hurts when they extend their knee against resistance. And, more often than not, I emphasize the why, right? So making a diagnosis is really easy for us. We get an x-ray, we do a careful exam, we have our diagnosis. But I think the harder part of our job is just to relay to patients, we have to figure out why this happened. Is it because the young athlete is tighter, went through rapid growth, has relative weakness, so tight quads, relative weakness of their hips and core, just doing too much on multiple baseball teams, playing throughout the year, et cetera. So we really have to identify strength and flexibility imbalances, for treatment, but two, for injury prevention down the line, so they don't get caught in this vortex of multiple injuries as they go through their growth phase. And there's nothing more, frustrating to our young athletes who come in with injury after injury after injury. And in my opinion, then we're not adequately looking at the risk factors that are occurring for these young athletes. We know that there's skeletal fragility, so weakness at this insertion site of that very strong patellar tendon. It's attraction forces, they bend and extend their knee, so running, jumping, basketball, for example. And then it's met with an increased volume in sport. And then, let's talk about the spine. So, and the apophyseal injuries that occur about the hip and pelvis. So we see these apophyseal injuries really everywhere in the body. And so we see them in the hip and pelvis. So in our young, for example, Irish step dancers, they have that very tight tensor fascia lata or iliotibial band that inserts right on that iliac crest here. And they come in with very localized pain over the lateral pelvis and hip. And we say, you know what, that could be an apophyseal injury. So we see them about the hip and pelvis. As we talked about the elbow, so the medial elbow, that little league elbow, the traction on that apophysis of the common flexor bundle of the medial elbow. We see them in the spine, the spinous processes. And I think of all the apophyseal injuries, the spinous process is one that's an easy one to detect, that tight lumbodorsal fascia, the tight muscles of the spine, and then focal tenderness as you march down the lower lumbar spine in the midline. And this can actually be a really tricky one to treat in that, it can be very painful and hard in terms of treating it from a pain and symptomatic standpoint. And I have even have braced kids and totally shut them down for 3 or 4 weeks to get these to heal, and then aggressive rehab to work on strength and flexibility and core stabilization. Then you see the, that arrow's misplaced, sorry, but the apophysis of the calcaneus. So this one we see a lot in our younger athletes, so 9, 10 years old, that are, that are wearing cleats, that are playing on turf, their heel hurts. We often see an irregular apophysis, which can be normal or can be when it's painful to palpation, symptomatic. And then we often can see it at the insertion site of the peroneal tendon onto the into the lateral foot. And so Osteochondritis Dissecans, so this is, as I talked about earlier, this is a disorder of subchondral bone and overlying articular cartilage. This, Dr. Michele taught me when I was a fellow, this is an overuse injury. And this can be one that's serious and can require surgery. And as a pediatric sports medicine doctor, my feelers are always up for, is there an occult OCD versus just simple strain to the knee? So I frequently get x-rays to make sure that I'm not sitting, especially in a sporty kid that's playing a lot of sports. And the parents will say, he just doesn't sit. He's running around all the time. He's jumping. When he's not playing sports, he's outside playing. I make sure to get radiographs if they present with knee pain or joint pain to make sure I'm not missing an occult injury to the osteochondral or subchondral bone. And these are unique to our young kids. They're overuse injuries. They're often related to, and the etiology is really unclear when you read the literature on these injuries. It's usually repetitive microtrauma, possibly some poor blood flow in areas that are really vulnerable. But more often than not, I think we have to focus on the biomechanics of these young kids. Is their knee dropping into valgus? Are they overloading that medial knee? Do they pronate a lot at the ankle? Are their hips, really weak, et cetera? So we commonly see this in the knees, the femoral condyle, the ankles, and the elbows. And the elbow, it's really unique to our gymnasts and our baseball players. There's different levels of the OCD, so I'm going to talk about that here. So it can be at the level of the radiocapitellar joint, as we see in our young gymnasts. Again, with the high impact and the weight bearing of the upper extremity. So this is unique to our young gymnasts. It's right at that radiocapitellar joint. Radiographs are often telltale, but not always. So we'll start with radiographs. If there's a subtle irregularity, we will often move forward to an MRI to characterize the lesion and help stage our lesion, which is very important in defining treatment. So what the stage of the lesion, is it advanced? Is it unstable? And is it unstable? Does it need operative fixation? So it's really important that we make an accurate diagnosis, that we get accurate diagnostics in order to stage the lesion to help really define our treatment. So here's the stages. So there's different scales, but stage 1 is a well delineated space with dense edges. So here is your stage 1. So your stage 1, you see it on X-ray, but it's very stable. It's subtle. In stage 2, there's a clearly distinguishable bone fragment in this space, and it may be separated from a loosened band, but the edge of the cartilage. So Dr. Michele always taught me that if the cartilage is breached and the synovial fluid enters into these lesions, that's an unstable lesion, and you have to act accordingly with the stabilization procedure. If the lesion is stable, and that's our job, to decide if it's stable or unstable, then you can treat non-operatively, relative rest program and try to get these to heal, especially in a young athlete whose growth plates are open. So my job is to decide, is it stable or unstable? And that really is the difference between a stage 2 and a stage 3 lesion. So a stage 3 lesion, the end of the condyle is no longer regular, the cartilage is fissured. So it really is a breach in the cartilage that I'm looking for. And is the synovial fluid tracking around this lesion, making it really not amenable to healing? And that's where the surgeons would have to go in and really fix that lesion. And then an advanced lesion is one where it's broken off and loosen the joint. And at these stages, the athlete often will say that they have mechanical symptoms. So the knee is locking or catching and getting stuck. And that tells me that maybe I'm dealing with an unstable lesion. So diagnostics, so radiographs I talked about, we get 4 views, the AP, the lateral, the sunrise view. For patellar OCDs, we get a notch view. We tend to see our notch view, our OCD lesions best in something called our notch view. So it's important to get a notch view. MRI is the gold standard, and that helps us stage the lesions, as I talked about. Our treatment, if it's a stable lesion, is rest. And these are the sportiest of sportiest kids that get these injuries. So this is probably one of the hardest injuries, in my opinion, to treat, because you're trying to rest a kid that's just not amenable to rest. So we often will relatively rest them and take them off of impact. So I'll put them in the water if I can, or maybe on a bike. But we really cannot have them impacting on the joint that's injured. So no impact running, jumping, cutting. We have to consider bracing, but again, the research is limited here. And we've been trying to look at bracing protocols in this injury for a long time, but there really it's inconclusive at this time. I often will use an unloader brace in the knee for an OCD of the knee, just to slow these kids down, to give them that, to remind them that they do have a significant injury. So I do often brace more often than not. If the lesion becomes unstable and we start to have those mechanical symptoms, or fails to show healing after imaging, in roughly 6 months, we consider surgery. And so let's move on to fractures. So we see pediatric fractures often. We have a Salter-Harris classification for these fractures. 15 to 25% of all childhood fractures involve the physis, which is the growth plate. Our classification, as I said, is that Salter-Harris classification. I suspect most of you are familiar with this, but it's always a good review. So this is the normal bone. So the diaphysis is the shaft. The metaphysis is that area just near the growth plate of the physis, which is that area of lengthening of the bone. The epiphysis is the area above the physis. So this is our normal. And then a type 1 injury can be just focal tenderness at the physis without radiographic findings, so an occult growth plate injury, or you can see some subtle widening of the growth plate, but this is your type 1 injury. These have a great prognosis, do really well. We commonly see them with the distal fibula of the distal radius. Their prognosis is good. You rest them. They really, because it's rapid bone growth, they heal fast. And this is a type 2 injury. And the injury is through the growth plate and above the growth plate. And these actually have a great prognosis as well. This is an injury that is through the growth plate and then through the epiphysis. And it extends. This can be, as you go up the chain here, the prognosis actually gets worse, and we worry a lot more about the integrity of the growth plate and the lengthening of the bone. And then the type 4 is above and below the growth plate. And these can be really significant injuries and require surgery. And then the type 5 is actually a crush injury, and the prognosis is poor. So what about transitional fractures? So these are ones that we need to be aware of. So this is an injury that can go through the growth plate, and actually it can be similar to a mechanism of an ankle sprain in a young athlete with a vulnerable, and this is usually during a time where the growth plate is fusing. And so this is through the growth plate and then through the epiphysis. It's the area of attachment of ligaments that are very strong, and they can kind of pull on that area and displace a fragment. The most important thing here is does it disrupt the ankle mortise? And if it does, it really needs to be fixed surgically and stabilized. So these are transitional type fractures. Other common fractures we see, so this is a buccal fracture. So this is unique in a child where their bones are relatively soft. And you see a little buckle in the cortex here. We often see them in the distal forearm from a fall, and these have an excellent prognosis. This is a green stick fracture, so the bend in the bone where only one cortex is violated, not the one side of the bone or one cortex versus the other side. So this is a unique fracture. Again, the mechanism is a fall on an outstretched extremity. The peak incidence is 11 to 12 years. It's in the girls and boys 13 to 14 years. And the prognosis for these injuries is quite good. They need to be diagnosed accurately and then treated. As I said, the bone rapidly heals, so the prognosis is good, but they need to be treated accordingly. I would be remiss not to talk about stress fractures. So we see stress fractures all the time, and it was amazing post the pandemic how many stress fractures we saw. So it just speaks to that that change in volume rapidly. So kids were inactive during quarantine. Many kids were inactive, and then they rapidly went back to sport, multiple layers, and we saw stress fractures all over the place. And I've been, doing this for a while, and I've never seen so many stress in the weirdest places too. So my feelers were up for imaging kids pretty quickly. If I had any bony tenderness at all, I was getting imaging fast because the stress fractures were so significant. It is a microfracture to the cortical bone as a result of abnormal bone remodeling and in the setting, again, of that repetitive stress. So this is an injury to the proximal tibia, and it can be anywhere from just mild edema to a significant, line through the bone. And it can be at all different levels. But we fortunately have an MRI now that really can make an accurate diagnosis. Greater than 50% occur at the metaphyseal diaphyseal junction at the upper end of the tibia. So we be aware that that kid that comes in says, yeah, my knee's just a little hurt. Someone says, oh, it was my hamstring that attaches, or it was a soft tissue injury. I'm more often than not, if I note a volume change or the kid's going through rapid growth, I will get the MRI to often look for that occult stress fracture. This is an important slide. So this is my tribute to Kate Ackerman. But we really have to be careful about our young athletes, our young female athletes in particular, during rapid growth as they increase their volume of participation. We have to make sure that we know that their bone accrual. So when do they increase the density of their bone? And really the time that they maximal increase in bone densities between the years of 11, 12, and up to 20. So in our young female athletes that are playing a lot of sports, we have to really be attuned to their energy balance. Like, are they getting enough nutrients to support their physiology? Are their menstrual cycles regular? And I ask that frequently in my young athletes as just a red flag question, just to make sure that they are not in a state of energy imbalance, because it is such an important time of bone density growth. And if we missed this window, we've really done them a disservice. So it's important to recognize that their bone density accrual is really during the years of 10 to 11 to up to 20. We have to make sure their energy balance is adequate. I have a low threshold for getting nutrition involved, and making sure that their menstrual cycles are normal. I often will consult with Kate or Bridget Quinn to make sure that their bone endocrine is up to par. Let's talk about the stress fracture, the spondylolysis. So there's a lot of interest in this injury because we see it a lot in our young extension-based athletes, or our gymnasts and our dancers, tumblers, cheerleaders. This is an overuse injury of the posterior elements of the spine. 47% of young athletes with back pain will present with this injury. So this is a good injury to recognize how the injury patterns differ in kids versus adults. So in a child that comes in, or a young athlete with low back pain, I'm like, stress fracture, spondylolysis. Versus an adult, we worry more about a disc disease, early disc disease, facet arthritis. We worry about nerve impingement. So very different profile in our adults versus our kids. 47% of young athletes with back pain will present with a stress fracture or a spondylolysis of the posterior elements. It's the pars, often, but not always the pars interarticularis, so the part between the facet joints, but it can be the pedicles, it can be the transverse process, it can be any of those posterior elements. It's repeated hyperextension and torsion. So in our gymnasts, for example, that are tumbling a lot, through that growth phase, 85 to 95% are at the L5 level, less at the L4, but we see them often. And then in our lacrosse, baseball, twisting, extension-based males, we tend to see it a little bit higher. So they can be at the L2, L3 phase. 80% can be bilateral. And again, the MRI is our best friend here. Radiographs I find not so helpful. So I tend to start with an MRI, which is can be tricky with the insurance companies. But if my my pretest probability or my clinical suspicion is high, I just go right to the MRI because it's much more sensitive. They can progress to non-union because the blood supply can be tenuous and up to, so this is a wide range. But if they're caught early and the child is actively growing, I think that we can heal these. And that's our goal, is to get these to heal. Less commonly, there's a slip where the vertebral body slips anteriorly, and that's more progressive and not as commonly seen. More often than not, it's just a stress fracture than a true slip or spondylolsyis. And so these are stages. So the CT can help us. So oftentimes, if I'm really trying to heal this fracture in a young one, I will get a CAT scan, not always, but many times, to help me stage. Is it progressive? Is it terminal? Is there a lot of sclerosis? Am I dealing with a more chronic injury that I'm not going to be able to heal this? And then I really just try to control their pain. Or is it early? And I can definitely get these to heal with strict bracing and a rest program. So the CAT scan can help me, and I often will do that in my young athletes when I'm trying to get these to heal. I'm going to talk a little bit, last 2 minutes, about overtraining and burnout. So this is McKaylee Center data for our young athletes. And we looked at this when we were trying to understand specialization patterns, et cetera. We know that kids start to participate in sports, and these are healthy kids that present to the McKaylee Center at young ages between 5 and plus or minus 2.3 years, and female 6 plus or minus 5 years. We know that, at this early, our specialization rates were for single sport athletes, just about a fifth, for double sport athletes, a fifth, and then 3 sport athletes, 57%. So this was good news to us that many of our athletes were multi-sport athletes. But, a large percentage were single sport athletes. So I think good to understand that in our athletes presenting to the McKaylee Center. The females, as I think, makes sense to me, tended to specialize more than the males. So 25% of the females were single sport athletes versus 18% in the males. And then what sports? So, our performance artist athletes in the females, dancers, gymnasts, figure skaters, and then soccer players. And then in males, it was soccer, baseball, and ice hockey. So again, this is McKaylee Center data. So a snippet of what we saw for participation. And then when Dai Sujimoto looked at this same database, it's not just about specialization, but his point in this study was that he found an independent association between increased weekly hours of training for a sport with a greater likelihood of a history of a lower extremity overuse injury. So this study really spoke to volume. And I really think, and Dr. Coker's done a series of studies that really spoke to the same thing. So as the young athletes specialize, they often will see more volume. And so it really showed that an increased training volume was an independent contributing risk factor for an overuse injury, and that single sport athletes trained nearly twice as many hours per week compared to multi-sport athletes. So that can be, so the underlying mechanism from this data was they questioned whether it was really a volume. And I do think volume is a big player with sports specialization overuse injuries. We define overtraining syndrome as extreme non-functional overreaching with a longer performance decrement greater than 2 months. So John D. Fiore defines this in his paper, which again is worth review. They can have more severe symptomatology, maladaptive physiology, and additional stressors not explained by other disease. So that's how he defined overtraining syndrome. It's a series of psychological, physiologic, and hormonal changes that result in decreased sports performance. So it's a complex topic that I think we're paying more and more attention to as we're starting to understand sports specialization and burnout in our young kids and pay more attention to it. They defined burnout. So burnout was initially defined by Smith in the mid 80s as a response to chronic stress in which a young athlete ceases to participate in a previously enjoyable activity. Young athlete withdraws from sport because they perceive it to not be possible to meet physical and psychological demands of sport, and they identify 4 stages of burnout. And we're really trying to pay a lot more attention to burnout. And we're going to pay attention to this as a big part of the Michele lecture coming up in the fall when we talk about specialization. And I think this is interesting. I found this when I was reviewing this topic, the development of unidimensional self-conceptualization and lack of control. And I think we just have to be aware of this in our young athletes and really, support their sense of self, their athletic identity, that they're more than just their sport, and really give them back their sense of control. And then we wrote a paper on the psychological implications of sports specialization and what are the risk factors in burnout. So extremely high training volumes, which really can affect, adversely affect sleep, which is getting more attention in the literature, and then family and social time, which, as a pediatrician, I think family dinners and family time is really critical to the mental health of our young athletes. There's frequent and intense coaching, there's high performance pressure, there's little personal control and perfectionism. So these were the identified risk factors for burnout. And then the integral play of low sleep, high stress, academic and sport stress, and then unfavorable mental status and that drive for perfectionism. And then their future expectations, are they playing to achieve scholarship or on the elite stage? And then how all these factors interplay to contribute to burnout in our young athletes. So in conclusion, I think overuse injuries occur due to repetitive stress during rapid periods of growth. There's increased skeletal fragility, and I talked about the vulnerability of the growth plate, and I used examples including the radial physis in our young gymnasts. We know that it's at a time with increased sports participation and volume. We know that there's imbalances in strength and flexibility. We often pay attention to neuromuscular control, specifically about the hip, pelvis, and lower extremities, especially in our females as they go through puberty. And I think Eric and Genna will talk about that. Prevention is key, and use your anterior knee pain as red flags for future injury, and really start prevention measures and training. And we need to pay more attention to the social emotional health and overall well-being of our athletes with attention to volume, overtraining, burnout, and loss of control. So thank you very much, and I'll end there. So I'm going to stop sharing and let Emily take it away.
All right, perfect. Thanks so much, Dr. Stracciolini. In the essence of time, I'm just going to move on and let Genna start her presentation right now. Genna Swanson is one of our physical therapists in our Norwood location of the Michele Center. So I'm going to pin her and let her take it away. So if you want to start sharing your screen.
Okay. Hi, everyone. So like you said, I'm Genna. I'm one of the physical therapists at the Michele Center in Norwood. I'm going to talk to you today about the physical therapy management and treatment of overuse injuries. I unfortunately see a lot of these injuries. It's more than 50% of the injuries that I'm currently seeing. I think the real challenge for a physical therapist in treating these injuries is to break the cycle of their injury, get to the why why their injury happened. Educate these patients appropriately. Unfortunately, the road to recovery can be pretty long for them because usually this injury is a long time coming as well. So providing the appropriate education for them, and then also getting them safely back to their sport or activity that they like to do. So these are my objectives, which you kind of went over as all of the reasons why it's challenging for a physical therapist. So just starting, I think Dr. Stracciolini did a great job of going over, overuse injuries from a medical perspective. Basically, a patient coming in, they've had an overload of stress onto their soft tissue, and they're having inappropriate recovery. Usually these are the patients that they say that, it started as a little pain and just kind of progressed over time. Sometimes they'll come in and say that, I just woke up one day with pain and I have no idea what happened. They present in the body like stress reactions or fractures, tendinopathies, osteochondritis dissecans, and Physeal injuries in young athletes. So when we look at the risk factors as to why this happened, one being that they have a rapid increase in training volume with patients that are in organized sports, this looks like their preseason. So if they go from a period of non-activity, during the off season, and they're not appropriately training during that off season, and then they go into a rapid increase in activity, that can lead to injury. So that's something to look out for in the preseason. With early sports specialization, there's a lot of literature out there. If you have a young athlete that is playing one sport for 11 months out of the year, they're having repetitive stress onto certain body parts, and they're not getting movement through the rest of their body. You can look at poor equipment. So an example being that runners who have shoes that they've been wearing for over a year, and then they're continuing to run on them, that puts a lot of force up through their body, and so that can present as some sort of overuse injury in their body. On the opposite end, if you have a like figure skater, for example, that just got new skates, but they're still having the same amount of training volume, that can also lead to an overuse injury. Change of environment. So if you have a runner that usually runs on a treadmill, but then they go to run on the road because it's really nice outside, and they're doing that for a week or so, treadmill ground reaction force versus the road, those are different forces that go through your body, so that can cause injury. Poor nutrition and hydration. So poor nutrition, with those athletes that have maybe a more a sport that focuses more on their physique, they can have pressures to look a certain way. So they might not be adequately fueling their body for their sport. Also, they could just have poor nutrition as a kid, and they're not getting the appropriate nutrients into their body. So that's something you need to consider. Inappropriate hydration. So if they're not hydrating enough throughout their sport, they can have a lack of balance of electrolytes in their body, and this can lead to fatigue and poor performance. Having the lack of recovery strategies. This is something we review all the time in physical therapy, having the appropriate warm up and cool down before and after practice. And then also inadequate sleep. So not getting enough sleep during the day. This can also cause challenges as well. And then one interesting thing that I saw in the literature was a shift from outdoor play to virtual play. So, in this day and age when people can, be watching TV or playing video games, they're not getting outside enough. And so you're going from a period of relative inactivity, being on the couch, watching TV, playing video games, to going right into your sport. So, that leads to some deconditioning from athletes when they're going into their sport. So if you see the kids on the left, when you're getting outside and playing, hula hooping, that's great for your core strength and building up your core stabilizers. Squatting down and playing in the mud, that's great for joint mobility. And being on a scooter, that's really great for your hip extensors and pushing back. And so you can get some strength in through your body that way. And so before I want to get into the treatment for these overuse injuries, I do think it's important to highlight the phases of tissue healing. When you're looking at a rehab process, when you're with these patients for a long period of time, they want to know why this is happening in their body and what's going on. And so for a physical therapist, we want to highlight the stages of healing and explain to them, what it can look like going forward, and how it can how their body has to heal over time. So I think it's important to, sorry, I know I was speaking too fast. My apologies, guys. I just saw those questions come in. So I think it's important to highlight with these patients that, just because, they could be a recreational athlete or they can be an elite athlete, but their body still needs to have time to heal. So just going over these very briefly. So you have the inflammatory phase. So there's redness, pain, swelling, and heat. This is when enzymes come into the area and they start the healing process. The repair phase, new blood vessels form, epithelial tissue migrates over the wound. Because of poor blood supply, there could be a pressure necrosis that occurs. Granulation tissue forms over the wound bed, and then fibroblasts produce collagen deposits over the wound bed. Maturation phase, this is when collagen matures and strengthens. Tissue is not very mobile and requires stretching and strengthening. I like to give the example of an old elastic band with my patients. So if you have an old elastic band, you go to pull it really quickly, the band will just break. But if you go to kind of stretch it a little bit over time, it gets a little bit more extensible, and you can stretch it more easily. The same thing works especially with tendons in the body. So if someone has like a tendonitis, for example, as their tissues are repairing and they go to they're not having as much pain anymore, and then they go to do activity. They want to go do activity, and they're like, I feel fine. Why can't I go jump right now? It's like, well, you might not have enough strength in that tendon right now to go back to your activity, and then you're going to cause another injury, and then we're going to be back at square one again. So we really want to make sure that we have a balance between stretching and strengthening of that tendon in order for them to get back to their sport. Just because something feels tight in their body doesn't mean that necessarily you have to stretch it. A lot of times, especially with those tendinitises, they feel like their muscles really tight, but really the tendon's really weak. And so we have to work on strengthening that and building up the strength in their body so that they don't feel tight. And so in overuse injuries, there is this improper healing because you continue to overload the tissue and you're not allowing these phases of healing to actually occur in the body. And so in tendinopathy, for example, you have a loss of normal collagen architecture and breakdown of tissue organization. And osteochondritis dissecans, you have a loss of blood supply in an area of the joint causing a small piece of bone to become necrotic. And then in stress fractures, you have a lack of cellular repair due to repetitive stress in an affected area. And so, in going through the phases of healing, we can, and reviewing and having the knowledge of these phases, it helps us to explain to the patient, when we get them into our clinic and when we're sending them on the right road to recovery, now this is what our expectations are. Your body hasn't gone through these phases. You haven't allowed them to go through these phases. And that's why we need to take a rest from activity and we need to build you back up in the appropriate way. And so in looking at the physical therapy evaluation, so this is my bread and butter. This is, what us physical therapists do. We first want to know the why as to, what is going on and how this injury occurred. So we start with asking the patient questions as to, maybe what did those few weeks look like leading up to the injury? Is there something that we can tease out that there was a change in their activity levels? Or their equipment or things like that, like what are the changes? We can ask them if they're a young athlete, have you gone through a growth spurt? Because that is certainly something to consider. So we really just want to understand why this happened, if we can tease that out, just from the subjective. Then we move on to actually looking at the way that they're moving. So we want to assess their movement patterns. If it's a lower body injury, we're looking at their gait patterns and how they're walking, squatting, performing single leg activities. If it's overhead, especially in the shoulder and full upper extremity, we want to look at their scapulothoracic movement patterns. So having them reach up overhead, out to the side, behind their back, and seeing not just where the injury occurred and seeing what's happening at that injury site, but overall in their extremities and in their spine, how is their body moving? And then after we look at the movement patterns, then we're moving into strength, range of motion, and joint mobility, and just seeing where there are deficits in those areas. So then in the early phases of treatment, a lot of the early phases have to do with pain management to begin with. So manual therapy, we work to improve blood flow and decrease pain. Certainly, we can also look at if there are areas of hypo or hypermobility. So hypomobility being if there is a joint that's really stiff, or hypermobility if a joint is moving too much. Whether it is a stress injury to the bone or it's a soft tissue injury to the muscle, it's, usually there is an area of hypomobility where something's not moving properly. And it's not necessarily in the area that they had the injury. For example, if someone has a stress fracture in their spine and their lower back, and that's usually where we see that happening, is in the lumbar spine, the lower back. A lot of times they have hypomobility, so they don't move in their thoracic spine. And so that's their middle back. And so we might have to look at their middle back and get that moving appropriately so they're not putting stress onto their lower back. So all things to consider with manual therapy, it really depends on the patient in front of you. Sometimes people are really hypermobile, and then you don't want to be doing those joint mobilizations to them. It's more about retraining their muscles, and we'll get into that. Next, we also want to look at offloading the affected area if needed. If they're in a lot of pain and they're unable to tolerate daily activities of daily living, then that's when we would look to offload the affected area. Also, depending on the severity of the injury, the doctor might also, from the imaging and their assessment, put them into some kind of bracing system. On the right, I have two examples for the lower back. So the top one, this is the Mueller brace. You can actually buy this on Amazon, and I use it with a lot of patients that have bony pain in their lumbar spine. And it can be comfortable, especially for kids that are in school. It makes it more comfortable for them to sit in class and tolerate the schoolwork. On the bottom, this is taping. So sometimes if their pain is more generated from their muscular structures, taping their skin will actually kind of help to lift and offload their muscles. So that's something else that we can try to use with them. Next, we want to look at full or relative rest depending on the injury. So sometimes a patient, if their injury is so severe, you do have to put them on full rest. But we try not to do that as best as possible. I work at the McKaylee Center at the Skating Club of Boston, and I see a lot of ice skaters. And sometimes when they have a lower extremity injury, they can't be on the ice and skating. But that doesn't mean that they can't keep up their cardiovascular exercise, because that will be important when they go back to skating. So can I put them on the bike, or can they be on the elliptical, or in the pool? Something that will offload them, and it will offload that affected area, and they won't have pain. Next, we want to look at, we want to get back the pain-free range of motion and strength. Range of motion being most important before we start to strengthen into the range, I should say. So we want to make sure that, depending on the severity of the injury, we would start with passive range of motion. So me moving them, going into active assisted range of motion. So that's them moving them, helping them move their affected arm or affected extremity. And then at full active range of motion before we do any kind of resistance going into the range of motion. But we can also start with strengthening too at the same time. So strengthening maybe not into the range, but doing light isometric strengthening. If it were the shoulder, if you were to put like resistance inside the shoulder, I'm not moving it, but I'm pressing my arm into my other arm and trying to hold that. So something like that you can start off with and then progress over time. But we also want to look at their neuromuscular reeducation. So that being, a lot of times when these overuse injuries happen, they're having poor biomechanics happening. So biomechanics mean the way in which their bodies are moving. If we take the shoulder example, again, a lot of times patients with their shoulder like slumped forward, and they have a really poor positioning of their glenohumeral joint and their whole shoulder complex. So a lot of times what we're working at is getting them to sit in a more upright position where their shoulder can be in the correct place. And so we work on working on other joints within the shoulder complex to make sure that we're training the muscles to be where I want them to be. So a lot of times I work on just having them practice rolling their shoulder blades up, back, and down. And now they're sitting with a better aligned shoulder position. And then in that position, when we start to progress them, they can start doing exercises and they're bringing their arm up overhead or out to the side, or they're starting to throw a ball, and they're in a better like upright posturing to help improve like the mechanics at their shoulder. And then lastly, we also want to address global impairments. And so, injuries don't just happen because of what's happening at that joint space or that joint area. It's happening because of other impairments along the kinetic chain. At the ankle, you don't just have an injury at your ankle. You have an injury at your ankle, but it's not because of just the ankle joint. There are things going on at the knee and at the hip, and also at the foot that we have to take into consideration. And the earlier that we can begin treating this and correcting these poor movement patterns, the better. So then once they start getting full range of motion and they're starting to feel a little bit better, we can start to begin to load the affected area. So we can start actually increasing the resistance. The general pattern that I like to go with is isometric strength before concentric strength before eccentric strength. So concentric strength is when you're pressing into the motion and you're resisting into the motion. Eccentric strength is lowering out of it. So you're coming slowly out of it and you're using that control. If it's a tendinous issue, so if there's something going on with the muscle or the tendon that attaches the muscle to the bone, we like to also use pain as a guideline here. So when you're going to strengthen a muscle that's you're already irritated, when you go to contract it, it's going to have some sort of pain. But it's okay if when you start to load it, it's okay for there to be a little bit of pain, because that's kind of expected because you're using that muscle. But we want to make sure that pain doesn't progress, that let's say that they can't do a full 3 sets of 10 or whatever reps and sets I prescribe them. We want to make sure they're able to do the whole prescribed amount without compensation. If they start to compensate, then clearly that it's too much for them. And so we'll get into it when I start to talk about the return to running and what that looks like. But we like to use pain as a guideline here. Also, we can start during the mid-treatment, we can start looking at the root problem as to why this injury occurred. So, once we start decreasing the pain and they're starting to feel a little better, we can start to load them a little bit more in more weight-bearing positions. We can start to mimic, functional activities, for example. So if it's a lower extremity injury, we can look at, squatting. We can start to do single leg activities. Like I always like to start with a step down off of a little box because it mimics a single leg squat, but you're not putting as much stress through their whole extremity. If it's their upper extremity, you can start increasing, their resistance as they go up overhead and start challenging them in different directions. And start to, progress towards some sort of sport-specific task that they'll do in later treatment. And then also towards the end of mid-treatment, we can start to take a look at, maybe their movement patterns that they need for their sport. If they're a runner, maybe we start to look at a little bit of a running analysis, if and when they're able to tolerate it. And then we can tease from that, from that analysis, we can tease, how to best gear our treatment going forward and what the best exercises would be for this patient, and that maybe we didn't see on initial evaluation because we couldn't watch their specific task that had been bothering them. If it's a thrower, maybe we watch them throw something like a light ball or something like that if they can tolerate it at this point. So then things are progressing well and we're going towards the later stages of treatment, and this is when we progress more towards a plyometric movement. I like to use the ladder to begin with my plyometric movement for the lower extremity. You can start doing like a little bit of jumping in it, and you can also do like quick movement patterns. And with it, I feel like because they're focused also on doing the task that you prescribe in the ladder, it slows down their movement pattern. So you're really able to watch like subtle biomechanical faults, like does their knee fall in, does their hip drop? Does their heel suckle at all or siggle? These are things we can kind of tease out, and then we can again gear other exercises towards making sure that we're able to prevent those sort of biomechanical faults going forward. We can start mimicking the demands of their sport. If they're a thrower, this is when we can start doing more throwing specific exercises overhead. It's, I like to do a return to run protocol for any kind of lower extremity injury for any athlete that has to do even some sort of running or even just some sort of impact through their lower extremity because I feel like running, it puts a lot of impact through their lower extremities. And so we can start to see, can they tolerate the load on their lower extremities, or is this too much right now? Do we have to pull back? And so it kind of gives us a good guideline going forward as to the return to sport as well. And then again, we want to prevent future injury. So it's still continuing to look at their full body and the full kinetic chain. You don't want to miss certain segments of impairments. And so we want to obviously keep reassessing and making sure that we're not missing anything in the kinetic chain. One example being, I have a dancer right now who's coming in with bilateral hip flexor tendonitis. So the front of her hip is really tight. And she definitely has some issues going on in her core and her low back. So we've been working on that. But she just started telling me today too that she's been having some knee pain. And so looking down the chain as well, she has really limited dorsiflexion, so flexing her foot up. She's always on point or pointing her foot down. And so when she starts to do anything with the squatting motion, she gets a lot of pain in through her knees because her ankles don't have enough flexibility to move her knee forward. So she's getting a lot of stress on her knee. So just a quick example, but we kind of addressed some of the mobility impairments in her ankle, and now her squatting is feeling much better. So always want to keep reassessing with our patients. So this is just an example of a return to run protocol. There's millions of them out there. This is the one that just works for me and the other physical therapists I work with at the McKeely Center. Before returning to run, we first have an assessment that we do, just making sure that they can tolerate loads on a single leg. So we're doing single leg step downs, hops, single leg calf raises, and then single leg balance with their eyes closed, and just making sure that when they're doing these movement patterns, they're not having any kind of biomechanical faults like a hip drop, so hip tilting to one side, or knee valgus, or any collapse like in their foot. So things that we've been working on in PT that we're making sure that before they return to run, these things are looking a little bit better. I always want my patients to have a warm up before their run. So this kind of harps back to what we were talking about with the phases of tissue healing, that maturation phase. So, that elastic band analogy. So we don't want them to go from a period of inactivity and doing nothing, and then all of a sudden running, and now you're pulling at, something that's maybe not as pliable. And so we want to make sure they're warming up first. And then they have their running. So basically it's a progression from walking more to running more over the period of 4 weeks. And then on the bottom, this is when we go over acceptable and unacceptable pain. So acceptable discomfort levels being general muscle soreness, slight discomfort that lasts less than 24 hours, slight stiffness or soreness at the beginning of the run that doesn't last greater than 10 minutes. Unacceptable discomfort levels being an increase in swelling, pain lasting more than 24 hours after training, pain that starts at the beginning of the run and doesn't dissipate throughout the run, pain that changes the way you're running, and then pain that keeps you up at night. So if they do have these unacceptable discomfort levels, we have them stop for 2 to 3 days and then restart their return to run again at the day before. So if they were on day 5, I had them start on day 3 again, and we retry it again. So then we start to look at the return to play. So as much as I want to be an expert on every single sport out there, I'm not. And so, we want to learn what the demands of that specific sport is. So starting to have the discussion with the athlete even at the beginning of their physical therapy, and learning what the demands of their sport are. There are some athletes out there that are only training 2 times a day and that have an overuse injury, or there are athletes that are training 6 times a week, and they have a lot more demands on them. And so the return to play for those two could look a little bit different. Also, if I don't know the demands of sport, I mean, there's so many great resources out there for sports that I might not be an expert in myself. And so just going towards the literature. When in doubt, we have that 10% progression rule. It's not necessarily has to be 10% each week. That can kind of vary, but we want to make sure that, they're progressing slowly over the course of several days and several weeks. I have a figure skater right now who's trying to return to sport after a lumbar spine injury. And he is skating 6 days a week for 3 sessions a day. It's a lot. That's a lot of impact and through his body. And so we had to think about how we're going to return his time on ice, the amount of jumps that he can do, because he does do a lot of jumping, and the intensity of those jumps. So single jumps have a lot less impact than doing a quad jump and rotating 4 times in the air. So we had to start with progressing the amount of time on ice first and making sure he could just tolerate skating, and then progressing the amount of jumps he's doing. So starting with like 10 single jumps, and then progressing that to double jumps, and then progressing from 10 jumps to 25 jumps, and making that being a long course, so like 10, 15, 20, 25. And then going to doubles and then triples and then quads. And so it's a long process that you have to stick with. But, in order to get someone back to that level with such a severe injury, it takes a long period of time. So as you can tell, though, as I'm explaining this, there are a lot of challenges with return to play. When a patient gets cleared to return to sport, they get really excited and they want to go back to the sport. They don't want to have this injury anymore. They're sick of being injured. And so, they might not listen to our advice as much. And this is where the education really comes into play. This is why out of the phases of tissue healing, you have to, make sure that these athletes understand your body needs to heal and you need to allow it to heal. And so, if they're going back to activity and having that little bit of impact, then they need time for rest as well. So their body gives time for it. Their body is allowed to heal. So that education piece being huge. They have pressure from their coaches, from themselves, and from their parents, people wanting them to be back and be normal and, do what they could before. But, we really have to continue the education and letting them know that, we need to take care of you right now. We need to make sure that we can return you back to sports safely. So this is a time period too to reinforce the importance of recovery program and the continuation of their home exercises. And so this can also be tricky with scheduling. So, again, they're looking to go back to their sport. So sometimes PT is on the back burner at this point. And so we really have to, emphasize that, physical therapy is still important to make sure that they have a safe return to play. Unfortunately, there can be an incomplete rehabilitation. So, whether that be because, insurance cuts them off, unfortunately, at this point, or if, because they're focused on their schedule, that they start to just put PT in a back burner. But, a lot of times with enough education and, explain to this patient the why it's going so slowly, they respond really well to understanding, what's going on in their body, and then how, we're doing the best to bring them back to their sport safely. Because at the end of the day, as a physical therapist, the best feeling is when you have your patient go back fully to sport without pain. So it's a good feeling. And so now I just want to focus on a couple of specific pathologies. I know I've been speaking in very general terms. Overuse injuries is a very broad topic that, there's so many different variables that go on in these sports, upper extremity injuries versus lower extremity, versus a young athlete to an older athlete, things that can be quite challenging with overuse injuries, quite complicated. So some common pathologies. So we have a spondylolsyis. So it's a bony defect in the pars articularis of the vertebral arch. As Dr. Stracciolini was explaining, it can progress, but very rarely to spondylolsyis. It's common in repetitive hyperextension and rotation. Sorry, it's common in sports with repetitive hyperextension and rotation. So that looks like gymnastics, figure skating, tennis, dance, basketball, volleyball. A lot of sports you hyperextend and rotate. So treatment, we want to avoid lumbar extension for the initial 3 months to allow their body to heal. There possibly is bracing depending on the severity. We want to have progressive core strengthening. I work a lot in the beginning to make sure that they're activating their deep core. So that's their transverse abdominis muscle. A lot of times with this injury, patients tend to overuse their lumbar extensors. So they're the muscles on the side of the lumbar spine, and they're really overactivated. So, and you see that they have this like increased lordosis in their spine, so increased arching. And so it's really important to get them to use that deep core muscle, not only as a bracing system, but also to kind of counteract those hip extensors. And then also we want to look at limitations in the other areas of the spine and their hip, and then also manage soft tissue restriction. So I have this image of a male gymnast on the right. He was not my patient, but I had a patient that was a male gymnast who came into me with this injury, which is also actually compounded with a disc herniation as well in his lumbar spine. So it was quite complicated. It had been going on for a long period of time. He was in a lot of pain, and he hadn't been performing gymnastics for about 6 months at that time. And so, you know, there was a lot going on. And so he showed me a video of him on the high bar. And what I noticed was that immediately, thank goodness I was wearing a mask because I think my mouth dropped, that his hyperextension is back, like right here, he was arching like crazy in his low back. He was using all of his lumbar extensors to swing around the bar, and he wasn't really engaging in his upper body or his lower body as well. So what I noticed with him is that, you know, he had poor hip extension. So because his hip flexors were so tight, he wasn't able to extend his hips back very well, and that put stress on his lower back. He wasn't engaging his glutes really well, which are his powerful hip extensors. So instead of extending his hips, he's actually extending his lumbar spine. His thoracic spine, so his mid back here, was extremely tight and limited in range of motion. And also his shoulders, when he went to go lift his arms up overhead, his shoulder mobility was limited. He wasn't able to fully flex his shoulders. Also, you know, his shoulder, he had poor scapular engagement, so he had poor scapular mobility and strength. And so when he did something where he was weight bearing through his shoulder blades are winging really out to the side. So he wasn't really engaging the muscles in the middle of his back. So all things that we worked on with him, you know, and, you know, there's a lot going on, but thankfully he's back to sport now, and he has not this perfect of a plumb line, but he's looking a lot better. So, you know, there's a lot of things to consider with this injury. Because we want to make sure that we're off balance, that we're, you know, decreasing the amount of lordosis, that amount of arching in their low back, and engaging all of the appropriate muscles. And so with that, you know, a very common exercise once they're able to tolerate a more extension is a bridge. This is one of the things I am a crazy PT about, that, you know, a lot of times patients will say, oh, I've done bridges, I can do bridges, and they lift their hips up and their back looks like this. So they're engaging their lumbar extensors and not really engaging their glutes super well. And so although a bridge is a great exercise, you know, it's one of the exercises that, you know, you get the most glute activation. We want to make sure these patients are doing it properly. So a great position to begin them in is lying on their stomach. Sometimes, so you're going to lie on their stomach and then activate your glute muscles and then lift your leg up, making sure that they're not having increased extension in through their lumbar spine, and they're not tilting from side to side when they're trying to lift their leg. Sometimes just lying flat on the ground like this is quite difficult. So I'll put a couple pillows underneath their hips at first and progress down to a flat position. And really working on, again, on activating their core muscles, making sure that they're having that appropriate stability in through their spine, and then being able to lift their leg by just using their hip extensors. Same thing on the bottom. So you can have quadruped hip extension. So keeping their back flat and maintaining a neutral spine, and then lifting their leg up in the air. And so really this is about disassociating the lumbar spine from their hip. And a lot of times with people with stress fractures in their spine, it's really challenging for them to make this connection, but an important one. So this is something that we want to work as early on as we can, as safely as we can, before giving them something like a bridge. So next, I have more of a soft tissue injury that I wanted to talk about. So Achilles tendinopathy is extremely common in athletes, especially in running and jumping athletes. So volleyball, basketball, cross country, dance. You have clinical diagnosis of localized pain, swelling of the Achilles tendon, and loss of function. Recovery is typically 1+ years. That's a long time. And so when these patients come in, usually these are patients that are really, really active, and especially in young athletes, and they, are trying to do everything they can for their sport. But, all of a sudden they have this pain and they're like, I've been doing everything I can. I don't understand what's going on. And they just want to get back to sport right away. And unfortunately, it can take a really long time depending on the severity of the injury. And, adherence to their home exercise program and education is like super important for patients. So treatment, when we think about Achilles tendinopathies, it's calf raises, and how best to do the calf raises. And we want to make sure that first they can withstand just doing a double leg calf raise, but then progressing it over time into an eccentric single leg calf raise. And it really depends on where you start them with this. Maybe sometimes like with the Achilles tendinopathy, going up onto their heel, there's at some point in that range of motion that they're getting a catch, or they're getting like a sharp pain. And actually working at an isometric at that area, and having them up on their toes, holding in that painful area, it actually helps to load that tendon appropriately, and actually helps to reduce their pain over time. But essentially with calf raises, you're progressing speed and range of motion. But then also, you want to think about with a straight leg calf raise, that's more of your gastroc muscle working. So that's the bigger calf muscle that you see, like if someone goes up on their toes, you can see the bulk of it and the back of their leg. But underneath that is their soleus, and their soleus does not pass the knee. And people tend to forget about the soleus when they're doing Achilles tendinopathy rehab. And so you really want to make sure that we're also strengthening the soleus as well. And we can do that really well by having them do a calf raise with their knee bent. So either sitting down, putting a weight on your knee, and then doing a calf raise that way, or also standing and then bending your knee, and then keeping that knee bent, and then going up on your toes. Either work really well, and they are very challenging for patients where maybe the straight leg calf raise isn't necessarily not necessarily as challenging. So just things to keep in mind with Achilles tendinopathy. But overall, we also want to focus on how did they get here? Much like any other injury, we want to look at their running and jumping mechanics, especially. A lot of times they collapse in through their feet, and they're collapsing in through their knees. So they're having this like medial collapse, and that puts a lot of pressure on their Achilles tendon. And so we're working a lot on getting them into correct alignment as they're either running or jumping, and making sure that they have the correct alignment in double leg and single leg. And then, with jumping mechanics, making sure that they look good on takeoff from a jump, and then also landing with a jump too, because at both parts they can have this injury. That can be the reason why that they're having this injury. And then lastly, I plan to go over physeal injuries in youth athletes. This just pertains to growing athletes. So it develops in response to excessive stress on immature bony and soft tissue structures. It's a combination of repetitive sport-specific tasks and rapid physical changes. There's a gradual onset of pain and dysfunction, and this looks like Auschwitz splatters, Little League shoulder, and Sever's. So when it comes to physical therapy, we want to have a period of relative rest and support from 4 to 6 weeks to 3 months, just depending on the severity of the injury. And then it's progressive strengthening over time. So just making sure that they can start to tolerate strengthening in that area of injury, and then also making sure that they're having appropriate strengthening of accessory muscles as well. If we're thinking of Oshkosh plotters, they're putting a lot of stress onto their knee as they're doing squatting mechanics, as they're trying to like squat or run. So we want to make sure that they have proper strength in their hips, and the mechanics from their hips down look pretty good, and also from their feet coming up. When we look at neuromuscular training, when an athlete's growing rapidly in a short amount of time, they have this period where they don't really know their body can't understand where it is in space. Sorry, their body can't understand where it is in space. So the proprioception is off. So we have to retrain their proprioception so that they're able to withstand various balance challenges, and their body can respond appropriately. And then lastly, we also look at flexibility as well, and making sure that overall their flexibility is looking good. So that's all I had to say about the physical therapy treatment. As you can see, it can be a little bit challenging, depending on the injury and the severity. These patients, when they first come into PT, they usually have had this injury for a long period of time. And so they come in, somewhat discouraged, but hopefully with the right rehab, they're looking better, and we can get them back on track. Yeah. That was my recommendation. I'll start sharing my screen.
Awesome. Thank you, Genna. So we are going to move right over to Eric, who is a strength and conditioning expert at our McKeely Center in Norwood, for the final part of this presentation. And if you do have any questions, feel free to put them in the Q&A section. We are going to do a little panel at the end just to go through and make sure that everybody gets their questions answered. And you can also reach out to hello@themckeelycenter.com with anything that doesn't get answered during this panel. So Eric, I am going to turn off my mic and video and
All right, I'm Eric, so I'm a strength coach, but my passion kind of lies in overall posture restoration. So that's going to be kind of where we're going to take this road today a little bit. We're going to kind of have you question some aspects of how the human body works and how we're going to look at overuse and how it's developed, and then how we apply strength training exercises to that. So getting into it, you're going to see overtraining syndrome. A lot is insomnia, loss of motivation, fatigue, weakened immune system, and joint pain. It kind of spins as a whirlwind as our overall systems of the body start to kind of decrease to slow us down to allow us for survival. So that's all the body is doing. It's trying to basically slow us down so it stays alive and doesn't burn out and doesn't collapse. But really, when it comes to overtraining, I think that's a tough word. I think people get too concerned with overtraining and overdoing things. Is it really just overtraining or just under recovering? Is it both, or is it not overtraining at all? So a lot of times people love to train. I have athletes that work multiple leagues of the same sport, club, high school, all at the same time. But then you kind of find out that they're not doing the right things of recovering. And that's a big aspect to this field, is not recovering enough. And we'll dive into that at the end, but just kind of get that ball rolling and think, is it really overtraining or is it under recovering? The other thing it is we're going to be talking about imbalance between stress and recovery. That's what drive these overuse injuries. I'm going to kind of take away that overtraining word. I don't really like it as a coach, and more replace overuse and compensatory patterns in its place, because that's really how it's going to start developing for us. Recovery is the most important aspect of training. And second, proper training in periodization is going to be important as we go through this. So what the athlete's doing not in the sport to prepare them for the sport. A lot of times we see athletes going through their sports, playing, and then they're not training on the back end. So they're overusing muscles, tissues, bones, tendons, whatever it is to get them to play their sport, but they're not taking care of it on the back end. Then lastly, the poor training modalities and recovery lead to overuse injuries. So someone could have a great training program, but it could be not in the proper position to allow them to be optimally working to prevent injuries. And we'll get into that as we go. Let's go to the next slide. So how does it present in the body? Dr. Strack and Genna went over this, but it's excess stress on a particular parts of the body trying to figure out movement. And that's going to be the biggest thing as we look at overuse, is the body has one thing and it needs to move forward and backwards and side to side and do all this thing. It's going to figure out movement at any cost. And it doesn't care if you don't have glutes on, it'll figure out where to put the glutes. As Genna was talking, you can use a lumbar back, a lumbar spine, a lower back muscles instead of glutes. Now those become your glutes. You can use a tongue instead of glutes. You can use teeth instead of glutes. The body will figure out where to put movement if that muscle doesn't work. So we see things like femoral patellar syndrome, shin splints, impingements, stress reactions, lower back issues, tendinitises, itises, inflammations that are going to stem up in the body because the body's trying to figure out movement and it's trying to put force in those areas. So a lot we talk about osgood slatters. When you see that, that's a telltale sign to us that there's that quad on whatever knee is going, it is overworking and it's telling the system, hey, I can't do this anymore, or I'm going to rip apart, or I need to gain more stability, more strength, put new bone down, take bone off. It will do whatever it can to create movement and keep them in the sport. Until it doesn't, then they get pain, then they just get discouraged. And as Strack was saying, we start getting that social aspect of burnout. And that's not where we want to get athletes. So always take in consideration, if we drive certain patterns of overuse, we can start getting into the neurological system and burning them out and having them have a bad relation with training, doctors, sports medicine, or whatever it has to do to pertain to that sport. So it is repeated stress placed upon the human body. Take running, for example, 3 to 5 times body weight force placed on the body as you take one step. Sometimes it can be higher. We've seen up to 7+ times body weight. And if you think about a 150-pound person taking a step at 5 times body weight, you're going to get 700 pounds of force on one step. Say they take 10,000 steps in a week, multiply that up, that is a lot of pounds placed on the human body. And if the human body is not able to handle that, it will start breaking down and it will tell you. It will tell us through pain. A lot of times you get shin splints, breaks. It will not be able to do it because our body has one thing only, and it's to survive. So it'll stop us and slow us down to keep us alive. The next aspect of it is not being able to get out of movement patterns. So as we are upright humans, we have to deal with gravity. And that is our biggest force factor. And we have to walk and do all these other things in life. But gravity is what kind of puts us in this pattern. We'll talk about extension pattern of overuse muscles to just get us through life. So muscles start to act as or for others, becoming primary movers of the skeleton. Lower backs will move us forward instead of glutes. Tight hip flexors will pull us forward instead of using abs, et cetera, et cetera. It can keep going. We can go down and up the chain through the foot all the way up to the skull on this. We then start to create tight and toned up tissue. As Strack mentioned, we're going to start dealing with tension. That is a problem to the human body. We like tension. We need to understand it, but too much tension will put us in a locked position. When that happens, you get compressed tissue. With compressed tissue, you get chronic low oxygen levels. That body will start sensing pain. These tissues need O2. They need to be able to move. If they don't get O2, they don't get nutrients, they can't recover. So what happens? You're either going to get cell death because they're not getting the nutrients they need, or the body will tell, hey, there's pain in this area and you need to address this. And that's when it comes to kind of the recovery aspect of it. Make sure we're doing everything we can to improve O2 levels and muscles moving throughout the body to allow tissues to recover, if it's injured, and to get optimal nutrients. And this is very prominent in younger developing growing humans. As we get hormones and growth spurts, we are elongating, widening, and our body has to deal and try to catch up with our rapid growth. So we see this a lot with younger kids, especially a lot of our patients, as they're hitting growth spurts, especially around puberty, because things need to change. And we got to think about this from a developing human at a young age. Let's say that's 4 or 5. When kids start to get upright activities and moving around, they're trying to figure out pressure, gravity, and everything else, and they're going to find it the best way possible. So also take consideration if there's young kids or you're working with young kids, teeth development becomes a huge role. So if kids don't have molars or certain teeth, their perception of movement might be off. So we have to take that in consideration, all going into our human system for overuse injuries. And as we learn these patterns stick with us and we adopt them as we age. And if we're not taught to get out of these patterns, that's when we start really developing these overuse compensatory strategies to play a sport. And I love sports. I think sports are great and everyone should be playing them at a high level in a multitude of volume. But I think it needs to be managed with the strength and conditioning world of strength training. And I think that's where a lot of people are missing the boat with. So to continue with it, the body's ability to move in and out of position is compromised. This is what locks us into a pattern. As humans, we are asymmetrical, so we need to understand that our right side and our left side are two different things, and they function differently. We have more organs on the right side than the left side. We have more nerves going down our right side than the left side. We are asymmetrical humans, but we try to perceive a symmetrical world, and that's how we can get stuck in these patterns. And we need, as the body, the ability to expand and compress on one side or the other. So if the left side compresses, the right side needs to expand, vice versa. If the abs contract in the front, we're going to compress the front, the lower back can expand. That'll decrease the tension on a lumbar spine. So we look at it like that. If we cannot compress one side, that means we're stuck on the other side. So if we're compressed in the back, so we have that lower spine issue, we're not going to be able to compress in the front. And that's where people get stuck in these patterns. And we get stuck in a certain state. As I'm standing here, it's upright, it's extension, it's chest up. The pelvis orientation is going to come forward. You get lower back lordosis. You're going to get this perception of tight hip flexors to hold you up against gravity, tight hamstrings, and tight calf extensions. This is where a lot of humans kind of start and lie, and then we add sports on top of this. We ask kids and athletes to jump, run at a high level, hit balls, swim, do all this stuff. So if we haven't addressed the position of the overall system, then we start adding movement on top of it. That becomes a very big problem. As we are in the state of extension, we inhibit certain muscles from performing their actions. So others need to compensate to be able to still move. The body, like I said, it'll find out any way to move you forward. It'll figure it out. And compensatory patterns will be relied on, and that will cause a sensation of pain. And this is where we're going to get into the topic of really overuse and kind of what actually is driving it and the why behind it. So a lot of people may not understand the why behind it. And I think for athletes and patients, having them understand the why is so important, to understand that they're just a human. And just like them, I have probably more compensatory patterns than they do because I've locked myself up and figured it out how to do it, but it's okay that you can get out of it. So reducing the injuries, this is tough because a lot of times people will prescribe rest and recovery, but actually it'll reduce the occurrence of pain, but it doesn't solve the overall problem. And that overall problem is the position that the human is in doesn't change. So if you don't address that, usually sometimes if they come back with resting and no activity, they'll come back and those symptoms of pain will come right back too because they technically haven't changed anything. They allowed their body to rest, recover, get new nutrients in, and take away inflammation. But once that pattern comes back, those muscles are going to be pulling and asking the same demand. So it's going to go right back to where they kind of started. And that's what we'll see with a lot of athletes. And in here, we're guiding them to come in, understand what's wrong with them, their patterns, and then retrain them with new patterns to show them that It's all about the human system. So as they resume, the pain is going to come back. And the only way to reduce tension of the muscle patterns is to shut those patterns off. Inhibit the chains by turning on opposite chains. So think if you have lower back tightness, your abdominals in front need to compress the rib cage forward to allow expansion in the posterior rib cage and aspect of the hips to reduce that same sense of tension. And that's what we do in the strength and conditioning world and here with our exercises. So a squat is just not a squat. If I take a traditional back squat and put a bar on someone's back, I can lock them up and drive their system into more pain without them understanding the position that I need them in. And then it's going to be teaching the brain to learn these new patterns and sequence them for optimal performance. And that is the goal of the strength and conditioning in here is optimal performance to understand tension, understand torsion, and to deal with that heavy impact of running, whatever their sport is, hitting a tennis ball, throwing a baseball, all comes with understanding force and tension in the weight room. So the solution, I say, is I have 3 R's here. So you got to reposition the axial skeleton. So we're talking pelvis and thorax. This will influence appendages, arms, legs, and mandibles. I cannot look at a leg or a foot or a knee or an elbow unless I address our axial skeleton first, because our state of extension, it pulls the spine and rib cage up. If we don't reset that into an optimal position, I cannot influence joints above or below that. And I think that's a huge misconception or a place lost for people where they start to go after ankles or dorsiflexion, but they're trying to get more dorsiflexion out of an ankle, but they can't even properly flex a hip. So if you can't get flexion through a hip, a rib cage, or a cranium, oftentimes you're not going to get that out of an ankle. So looking at the body as a full system needs to work together. This is where we'll start to see patterns of collapsed feet, high arches, external rotation, internal rotation. The body will figure out ways to put movement patterns together and compensate for the lack of movement at this axial skeleton. So when I see flat feet or high arches, that doesn't bother me. It just understands that the body is telling you a sign to figure out how it's trying to get movement, where it might not have it at the rib cage and the hips. And that's where you see if you do table tests or testing, range of motion will come away, but you can reset that once you reset this axial skeleton. And once you do that, it'll put slack on certain anti-gravity muscles, so it will inhibit that. So if you posterior and get a hip to neutral, those hamstrings will love you for the rest of your life. Then it's to retrain. So teach the brain to turn on the proper muscle chains at the right time. Firing and timing is what we are training in this weight room. I tell my athletes, I don't care if we're strong. I don't care if we're fast. I do care, but I don't. It's all about when they hit the floor or they're moving that weight, are the proper muscles firing and can they do it quickly? Because when we get to sport and we're running at 100% intensity, those things are happening in milliseconds. So I need them to be able to feel and understand in there that same concept to help them, whether it's on a court, an ice rink, in a pool, on a field, it doesn't matter. And then we're going to restore. We're going to create reciprocating alternating activity. Can you do something on your left side and on the right side without getting stuck in a position? And that's going to be our end goal, to restore that. So reducing injuries is the ability to get neutral. And I'm sure a lot of you have heard this word before, neutral. It's not about a particular posture, rather the ability to restore capacity of movement variability. So can their arm, ER and IR, with the right degrees? Can they do it on both sides? Can they shift to the left? Can they shift to the right? Can they get off a left leg? Can they get onto a right leg? That's the important stuff of what we're talking about neutral, of passing through left and right. If you can't do that, we get things like impingements. We impinge shoulders because we can't come out of that position. We impinge hips, knees, feet, teeth, eyes, you name it, we can impinge it. And then gaining symmetry or neutrality is the ability of the body to perform reciprocal alternating movements. So we're still restoring that. We're getting side to side. This is walking, this is running. This is allowing the athlete to have freedom of movement. And this will reduce tone and tension of muscle chains. Chains need to turn on and off at the same time. This will unlock the nervous system in triplanar motion, because we know that all sports and all life is triplanar. Yes, we have multiple planes, but as you step on a field, get out of a car, we're moving in multiple planes, and we need to be able to turn, rotate, extend, and flex in the proper position at the right time. So the solution, a lot of times people think stretching is the go-to if they have a tight muscle. Well, here kind of, if you believe in that, great, but stretching might not be as effective as people think unless you're repositioned. If you're stretching a muscle in a position of extension that's already tight, you could actually be causing worse problems because you're lengthening an already lengthened muscle. Yes, to your brain, it feels like you're stretching, but you're not influencing position of the axial skeleton, the thorax, or the pelvis, ribcage, or hips to change anything. So this is where people do a lot of stretching, but as soon as they get back upright to gravity, their normal patterns will return. So start to think about your activities. Are you overstretching or overdoing something that's not really working? And sometimes it only targets the painful muscle area, but it doesn't address the whole system. If the system is still locked up, long and tight, you're not going to change anything. A good example of this is hamstrings. A lot of people have tight hamstrings because of our pattern. Our anterior forward tilt of our pelvis makes those hamstrings long and out of position. So what do people do? They stretch hamstrings all day. If there's one thing I tell athletes, runners, especially our gait retraining, hamstring stretching will destroy your programs all day, because you're going to create more extension and more tone for those hamstrings, but you're not creating strength and the brain's sense of position to allow for optimal function. So first, we're going to talk about the pelvis. So we have that anterior orientation. If you go back and watch this when this is online and look at Strac's photo of that pelvis, yes, you'll see the injury, but you'll also see one pelvis is a little bit higher than the other pelvis. And as you go back and look at images, whether you're a PT, strength coach, or just want to go online, start looking at bones and images, and you're going to see left and right differences of how the body's going to adapt to its world, its sport, and that's going to start telling you how the body is oriented through that. You're going to see, especially in pelvises, that right one is going to be a little bit higher and oriented to the right, where the left one's going to come forward and down. So resetting the sagittal plane is going to allow the pelvis inlet and outlet, so you have the top and the bottom, the pelvic floor, to open up and allow movement for the legs. This will help with knee pain. This will help with ankle pain. This will help with patellofemoral syndrome, all that stuff, by allowing position of more IR and ER through the femurs, because the hips can now move. After you do the sagittal plane, then we're going to go after the frontal plane, so the side to side. So a lot of times with runners, we see tight or weak glute medius depending on the leg, and we need to be able to understand that if we're running or forward locomotion, we need to shift and stand on one leg. We need that leg to understand how to hold itself up. And then that pelvis, once you get it in reposition, it puts the hip flexors on slack, so it's inhibition, and allows them to function when they need to. So it decreases the work they need to do an upright activity. When we get in this extension pattern, most of the time you feel like you're going to fall forward because the gravity wants to take us there. That's normal. So those hip flexors are holding tight to not let you keep going forward. Once you bring that system back a little bit, those hip flexors are going to be like, hey, I can do this. I can survive here. And they're not feeling threatened. Then we're going to get into the thorax. So this is what sits on top of the pelvis. This needs to be able to move. And once this is in position, it allows the scapula to rest on the rib cage appropriately. And this will allow a proper movement of the shoulder blades on the rib cage. So now we're in the spring, summer season. We see a lot of baseball players, a lot of throwing athletes. If this rib cage is in a non-optimal position and that person is throwing and external rotating into IR really fast, they're going to cause a lot of problems either at the elbow or the shoulder. Impingement, throwing elbow. We've seen a lot of increase of Tommy John surgeries because people are blowing out elbows because they're overthrowing and they don't have the strength of a rib cage muscles, shoulder muscles, to allow for that amount of velocity and force to be placed on it. So resetting the rib cage with those muscles and then training on top of it will allow optimal movement through the arm. And this is going to go through and influence the positions and movements of our humeroglenoid joint, so our shoulder joint, our radial ulnar joint, and even the wrist joint. So we're looking at all these joints up and down. If someone's very much on their hand, I know we talked about Gymnast. So understanding that resetting the thorax is key to addressing possible wrist problems if they have it, or whatever upper extremity issues that they're dealing with. So now we're going to get into the training and what areas to work on to help reset what we just talked about of understanding thorax and pelvis position. So abdominals are going to be the most important thing to focus on. Internal, external obliques, transverse abdominuses, those are going to be the keys to holding us together and allowing us to create that less demand of the extension pattern and create pressure, understand pressure as we move through and play our sports. So the position of the thorax will allow the diaphragm and pelvic floor to contract appropriately. Those need to time up together as we inhale and exhale. Next, we have the hamstrings, our kind of second go-to heavy hitter. They're going to pull the pelvis back into optimal position and hips position. If you have a person with Osgood's ladder, hamstrings are going to be money for them, which they'll pull the pelvis back to reduce the tension that's placed on the quads, that is placed on that quad tendon at that attachment point that's giving them pain. You reset that and teach them how to have quads and hamstrings and glutes on together, you're going to decrease that need for tension right below the knee. And that's how we're going to start to look at training muscles and movements to decrease where pain can be put in overuse injury. And then ankles, to increase the tissue resiliency and be able to accept and understand load. A big one we see with athletes is shin splints, and they're trying to figure out how to move fast with hamstrings that are not optimally in a position and glutes are working. So those medial shins, those anterior tibs are going to take a lot of the load, and they're going to figure out how to internally and externally rotate and move that foot around. They can only do so much if the hip can't help them. So that is going to be another training area to work on. And then the training goals. So in the weight room, we need to teach the body to understand tension and torsion, create it and manage it. Because if someone doesn't understand it and deal with it, they're going to fall apart. So when we're looking at a squat, probably the best exercise you can give someone, if it's out of position, that tension is going to drive that system up in a negative way. If that person doesn't feel tension, that means they're just kind of going through the motions and they don't understand it. So as Genna was saying, isometrics are the way to go, starting off on a training program or getting someone back from overuse to have them understand what tension feels like. And I'll have them sit 20, 30 seconds in a low squat position, have them deal with tension and feel what glutes, hamstrings, quads feel like, a bunch of other muscles working to understand it. And if once we can teach the brain that, then we can start working on others. You can't just start, in my opinion, throwing exercises on a board and hoping to target those muscles. It all has to be about position and having that person understand the tension of that position and that movement. The next is going to be to teach the body to absorb force. A lot of times why we get injured, why we break down is because the force placed on our body can't handle it. You ever take a popsicle stick and you bend it enough, eventually it's going to snap. The human body is going to do the same thing. So as we add resistance and progressive overload in the weight room, we are allowing our body to withstand and hold more force. The tissues become more resilient. They build stronger cross bridges. They put down more tissue. They put down more elements to be able to withstand that force when they go onto the field. So in the weight room, the more I can overload someone and get them to understand force, whether it's through movement, isometric training, or conditioning, it allows them when they go on the court or field, their body's like, oh, this is nothing that I experience in the weight room, and we're safe and we're limiting injuries. And we want to put force on the body to teach it. That's all we're doing in here with weights. It's not about getting bigger, faster, stronger, look the best. It's about how well that they can manage it without getting injured. Because we don't want to see these athletes come in here with injuries time and time again. That starts hitting on their neurology. They don't like it. it burns them out. We want to make sure they stay injury free, staying in the weight room in the training and staying on the ice, on the court, on the field. So they're like, hey, I feel great. And then allow the muscle chains that we want to turn on to learn that tension and torsion. Because as we are running and jumping, things need to internal rotate, external rotate, compress, expand, adduct, abduct. We need to teach the body to understand what that's going to look like through muscles. So some repositioning techniques that I use a lot and through PRI what we use, I might have blacked it out, or there's YouTube videos. You can always search the dead bug video with plate overhead hold. So the ability to exhale and feel that lower back being compressed into the ground and creating that thorax and hip stacking position where one is over top each other, just in a supine position, allows for optimal function of a diaphragm and the muscles to understand force and tension. The other ones that go to that might be unavailable now, if you need the link, we can always have it sent out to you, but it's the 90-90 hip lift. This is a go-to for hamstrings. So picture yourself on your ground with feet up on a wall in that 90-90 position. You are targeting abdominals, glutes, and hamstrings to function and work together. So we're timing that muscle chain up together. That will take tension off calves, quads, necks, you name it, and reteach the pattern of a neutral state of pelvis and a thorax. And then when we get to strength training, when it comes to athletes, we're always talking about full body resistance training. A lot of times I'll get this question a lot about, body splits. Bodybuilding stuff does not work. It's more sagittal. It locks athletes up. It is not optimal. It's really not optimal for like humans in general because we need full range of motion side to side. So full body is the way to go. You got to work in all planes of movement, front, side, back, rotation, twisting. And we're strengthening tissues for one goal, and that's force absorption. Can they land and absorb that force and not break down and fall apart? That's it. Early and often in the program, or your program that you write, isometrics and eccentrics are the go-to. That's going to allow that body or that athlete to sense what tension is like. So holding, slow lowering remodels tissue to understand the force that you need to put on it. And with that, you're going to control your own position with the appropriate muscles on. And that's the big thing. A lot of time, a lot of athletes will get into these programs and they're just like, hey, go squat 25 reps. Well, it doesn't matter about the 25 reps or the rep scheme. It's the position that the squat's in and the alignment of the body. I get very particular biomechanics when it comes to squatting, lunging, or anything else. Most might be used to squatting with externally rotated feet, knees out. When you think about something like that, athletes really don't run like that. A wide stance squat is not going to be beneficial to an athlete, and we're just driving more external rotation. If they already have foot problems, that external rotation is going to cause more problems. So when I think about training, I like to line up everything neutral and have them understand going forward in a forward locomotion pattern, what that should look like and feel like. And at first, it's very hard to reposition someone in an exercise to where they might not understand where their body's going. They might collapse feet, knees might collapse. They might not be able to understand the movement. That's okay. That's why we're here to teach them. But understanding that position in the weight room in strength and conditioning is the most important thing, because you could have the perfect program, but if that athlete does it all with a position of extension and lower backs on, you're just going to drive them to be less performing on the field and more prone to injury. So with that, we look at exercises such as squats, lunging, push-ups, step-ups, chin-ups, jumps, you name it. The exercise, the spring ankle you see on the screen, that's a go-to to understand tension of the calf. So you play the video, you're going to lift the hips and you're going to feel your calves working, and you're going to build up to about 60-second holds. This is going to teach the body to understand that tension. So if you're a runner and if someone has shin splints, this is one of my go-to exercises to strengthen their posterior aspect of that lower leg to allow that anterior tib to shut off and relax. So then reducing overuse and overtraining as a whole, as a coach, we like to say quality sleep is important. 7 to 9 hours. Your body needs to heal and recover as we sleep. Hormones are highest at night. That's when there's most building going on and through the system. And most of the time nowadays, I know with cell phones and social media, kids are getting less and less sleep. That's becoming a problem. Even as adults, we're creating a problem. But that's going to be the main thing. If someone's overall system is too high running, they're stressed out, we can't really influence a lot of injuries because that system's still going to be in a stressed out state. We're not going to be able to address tone and tension down below. So sleep has got to be a top priority to allow for healing. The next is good nutrition to fuel and help the body recover properly. Optimal protein, carbohydrates, fluids, that's the go-to. You need to help build and replenish and grow new tissue to prevent injury. The worst thing we see is athletes do all the right things in the weight room, training, rehab, PT, but their diet is not optimal, so they're not taking advantage of what we're trying to create adaptation-wise on the strength floor or wherever, and they're still missing the boat, and they're not getting optimal return to play or return to their sport. And then strength train, proper programming. So even at a young age, we see kids as 5 and 6 here, need to be taught movement patterns and strength and teaching tension. So from a young age, we need to start instilling this, especially nowadays. I think a lot of people jump too early in this country into sports and not enough onto the training. So they now, once they start strength training, they kind of put the blame a little bit on the strength training as the overtraining and not the overall demand of their sport. But if they get proper strength training, guarantee you that they're going to stay on that field. That person's going to stay happy and they're going to have a good relationship with their sport long term. And that's what we look for. And then kind of overall, we're going to perform low intensity aerobic work. That could be twice a week. This is going to allow for optimal nutrient delivery to the body. It's going to allow to get proper blood flow through, relax the autonomic nervous system, and to increase the ability to have capacity for that sport. And then usually every 4 to 6 weeks, have a download week. So this is going to be a less intense week, allow for super compensation, allow the body to really recover. And this is not only applied to the strength training world, but I also believe it should be applied to the sport world. We get in this world now where we're like 365, we're playing baseball, we're ice skating, we're doing whatever it is. We need blocks of time where that person is relaxing, doing something different, going to go play pickup wiffle ball and not overloading the system too much. And that's where I think we need to guide athletes to say, hey, it's okay to go 3 weeks off of a sport. You can still do some training and working out, but you don't need to be hammering that. Allow your body to completely recover and those tissues to completely shut down. Usually for a lot of athletes, I recommend after their season or heavy competition, take 2 weeks off. Still do light training, light aerobics, but don't do your sport. And they come back refreshed, feeling great. And at the end, we're going to always look for forward locomotion training. This is going to place the highest demand on the body. And this is what we do daily. So our A skips, high knee runs, bounds off of a single leg, hops, jumping. This is all going to allow proper development of tissue, tendons, and bones and growth to understand that tension and torsion. And the last thing was deceleration training. That's absorbing force. So can that body absorb that force? And then once it understands it can absorb force, it can now push that force out to be able to propel themselves forward and be good at their sport. And lastly, any questions you have? This was my client at 6 a.m. this morning. Wasn't too happy with me, but I think we did a good job with him. I appreciate your time here this morning on a Saturday. If you have any questions, I think we can drop in the question box and answer anything, and I'll toss it back to Emily if there are any questions.
All righty, perfect. It looks like we, of the people that had asked questions in the Q&A, only one person had one that was in there, and it was about avulsion pelvic fractures. And it looks like Dr. Stracciolini already responded to that one as far as the time frame for that. So if anybody has any further questions, feel free to drop them in there. And if it's something that you want a little bit more information, again, you can always email us at hello@themchaleycenter.com. looks like we have one question in here. So on rest, how about 1 day off per week, say with active rest? So I'll let you guys take over for that.
Usually for active rest, I like, if you're going hard on a sport, at least 2 days in a row. Sometimes 1 day is not enough. Even with training in myself, like 4 or 5 days of training and then weekends are off. It is heavy rest day. You're doing some recovery, whether it's an ice bath, go to the beach, relax, but the body really needs time to shut down. And that's any age of person. Like, so I would say at least 2 a week.
Awesome. Thanks, Eric. How often do we see recurrent hip avulsion fractures after they heal, and does it occur on the other side?
Not that often, honestly. So Kim, we see them often about the hip and pelvis in our young athletes, or common injuries that prevent, usually in a male, tight male. Soccer is a good example of the rectus or the hip flexor inserting on the pelvis. It's that pop, that immediate like burst activity. You get a pop, you get the x-ray, you see the avulsion. They heal. The prognosis is excellent. With good training and rehab and attention to strength and flexibility, we often don't see them recur.
Great. All righty. So last call for questions. I do want to say thank you to everybody who joined us today. And as a reminder, the recording of this lecture will be on our YouTube channel sometime midweek the next week. And Stacy will also be sending out a link to a quick eval. If you are someone who paid for credits, she will send your certificate next week via email. The next lecture in the series will be coming this fall, so just make sure that you keep an eye on our website, mccaleycenter.com, check your email and also our social media pages. So again, I want to thank Dr. Stracciolini, Genna, and Eric for being here this morning, and thank everybody for coming, and I hope you all have a great weekend.
Just a plug for our McCaley lecture in September 25th. The topic is sports specialization. Come one, come all. It's going to be an awesome day. 2 awesome guest speakers. So
wonderful. All right. Thank you, everybody. Take care.